So his review of Charcot today will cover imaging cases, and I will do radiographic angles next week. So pardon the flip of schedule, but you'll still get everything covered since we're not going to be returning to normalcy anytime soon here. But while he's presenting, I am going to be in the chat room. And what we would like is Friday was fine running the chat room with all the questions being answered there, but this is really practice, verbalizing everything on your end. So we'd like more people to verbalize. We're not going to be harsh. We just want to help get everybody better. So hopefully today we'll have some more participants. But I'm going to let him take over now.
Alrighty. So today's lectures, like Dr. Rosante says, is going to be on Charcot, and I put a lot of stuff in here. A lot of stuff we'll just kind of breeze through and then kind of get to the imaging, but I think a good understanding of Charcot, maybe a little bit outside of the classroom setting, is not a bad thing to go over. Plus I need to fill the hour time slot that Dr. Rosante gave me. So we'll get started as most Charcot lectures do with the corny picture of a shark. But for educational or background, it's kind of good to know where it came from, this neuropathic arthritis back in the 1700s that was mostly with venereal disease patients. And then on to reported cases of these tuberculosis patients in the 1800s. A little bit later in the 1800s, the same kind of thing seen with wounded soldiers after they had spinal cord injuries. So these neuropathic patients, after they had traumatic injuries to their spinal cord post-war. And then here's Papa Charcot. So this Jean Martin Charcot kind of really being the one who explained this the best and the most in the literature. So we've first talked about this painless joint swelling, and then what kind of came later on, this arthropathy associated with tabes dorsalis, and he explained it in the late 1800s, kind of that these patients, they started beginning to suffer a deformation of the feet. And he thought he had a sprain, but couldn't remember any trauma. So a lot of these patients, they don't necessarily have this large traumatic injury that they can recall, but all of a sudden their foot becomes deformed and everything starts to go downhill. Other notable contributions out of England, Dr. Tooth from England described CMT with his residents, kind of explained that in a couple different articles. So just for completeness sake, you guys can kind of look into that stuff so I don't bore you today. In the 1936, that's when diabetes and Charcot started to become kind of synonymous, or discussion regarding these diabetic patients. And around that time, diabetes in the United States became a little bit more prevalent. And therefore, with that came this neuropathic manifestation of these uncontrolled diabetics. So there's a couple different theories that we'll just touch on here. The first one being the neurotrophic theory, where the lesions result in a bone nutrition deficit, which causes this arthropathy that causes the degeneration of the bones in the joints. There's no real trophic factors, there's no real backing behind this one. This was more of a theory that was didn't really have too many legs to stand on. The neurovascular theory in the 1960s by Johnson, he first described this as being like a neurovascular, so both neuropathic portion and a vascular portion that causes the increased blood flow in a region, failure of the sympathetic nervous system, and therefore causes that increase in pulse pressure, those bounding pulses that we can see in Charcot patients, and then an overactive bone resorption. So Our creation and resorption of bone is supposed to be at an equal rate, and with these patients with this neurovascular theory, don't have that regulation to make sure that the bone resorption and creation is equal. Then became, or a little bit later on, this neurotraumatic theory. So some kind of trauma that started the cascade, which causes this arthropathy and mechanical microtrauma, and then causes this breakdown of their pedal bones. They first started describing this with tertiary syphilis patients, and then saw this bony breakdown with it. And then reacting from initial insult, this bone resorption due to an increase in cytokines, the whole Rankel cascade was later described too. And this is a nice little boring article, but really the symptomatic and neuropathy or an unregulated cytokines. The strange thing of this Charcot disease is that it should be simultaneous or bilateral, because if this is a systemic disorder, just having the reasoning being a sympathetic neuropathy and unregulated cytokines would point toward involvement of bilateral. But the literature's in 2005 shows only less than 1% of the patients get bilateral involvement, and then only about 10% get it bilateral after the original foot gets it. So, we look at these X-rays and we kind of see these calcifications, some kind of abnormalities in the feet, especially with our stage 0 or stage 1, stage 0, not stage 1. And then this cascade shown on the left-hand side of your screen, just talking about how the neuropathy is what starts this entire chart or flow chart and goes all the way down to the subluxation and degradation of bone. So we define Charcot as a progressive non-infectious destruction, an inflammatory process seen in patients with some kind of somatosensory neuropathy. And that was what the ADA kind of defined as what exactly is Charcot in 2011. Now, neuropathy is seen in multiple different pathologies. United States diabetes is one of our biggest ones. Alcoholism also. So, obviously when we're talking to these patients, and they deny having diabetes or deny having long-standing and uncontrolled diabetes, before we skip to idiopathic, we want to look, at these different things. Do they have alcoholism? Thursday. Alcoholism, tabes dorsalis, that kind of goes down the line of different things that cause neuropathy and then indirectly cause the Charcot deformity. So when we look at these patients, pardon me, the red hot swollen foot is obviously our main diagnostic tool. Temperature changes how warm the leg is compared to the contralateral limb. So primarily it's a clinical diagnosis. Bounding pulses isn't seen in everybody, but it is seen. It's something to look for. The red hot swollen foot, this deformed look to the foot. And then kind of going down the line, which kind of special attention, what kind of things may have caused this? A past trauma, an ankle fracture from way back when, or an ankle fracture that was not fixed. What kind of edema changes have they had? Erythema, and usually there's a combination of multiple different things that you see on the clinical diagnosis. Neuropathic patients present with erythema and edema are often misdiagnosed. So the range of misdiagnosis ranges from 25 to 79%. That's a very large, it's a very high number, which is kind of a quote unquote scary number of all these patients who are not offloaded and taken off of their Charcot deformity. And by the time that it's caught or by the time that it's properly referred after they've been treated for gout and cellulitis and sometimes DVTs, or even osteomyelitis if there's an open wound, but with the Charcot destroying the joints, sometimes it's too late, which is why a lot of times the standard of care is amputation. So we look at these patients and what they kind of discuss of what happens. Sometimes a lot of times there's a diagnostic delay, about 29 weeks on average for the literature, and by that time, like I said, there's a lot of damage that has been done. Our average patient being around 57 years old, usually a long-standing diabetes. In this specific study of diabetes care in 2010, it's about 15 years long-standing diabetes, and most of those years are uncontrolled. 80% of those diabetics have been diabetic for 10 years or more. And unfortunately, this mortality number is very similar to those of the amputation mortality that we see with the 50% of patients after their first amputation are dead within 5 years. It's a lovely, boring article out of the VA, but it does show how much
like one of those
future stuff. It shows how bad this
Lina Kugels and Sandusky or ask Danielle.
Your mic.
Yeah, I'm not positive on that one.
Sorry, that's my fellow. So infection. So a lot of times we have this infection, and this is kind of leading into the X-ray portion or the imaging portion of Charcot that I want to go through. The involvement, direct course, that's okay. Direct course through the opening in the skin and hematogenous spread is not common, which is kind of strange. But usually that involvement of the bone underlying a wound of a Charcot is contained within the periosteum and within the bone itself and does not go systemically. Obviously, abscesses that can occur with these patients lead to sepsis or lead to further infection and systemic signs of things, systemic signs of infection. But a lot of these patients do have just a localized Charcot and a localized wound and osteo. Brodsky had a nice little study, I think in the late 90s, where he described a simple test to differentiate whether or not it's Charcot versus infection. And with Charcot, the edema usually decreases with elevation versus infection, which the edema does not decrease. So just kind of a little tip and quip there. X-rays often on the initial exam, they're the least sensitive, especially if it's an acute and active stage. Usually the X-rays or the X-ray showings or findings aren't seen till later. CT scans, those are my favorite to get for Charcot, especially when you're planning for reconstruction or surgery, because you need to look at these CT scans to see the integrity of the bones, how cystic the bones have become. A lot of times the MRIs they're lit up like a Christmas tree, but that doesn't necessarily mean that those bones are infected. They may just be have a lot of uptake because of the marrow edema, a lot of uptake because of the microfractures that have happened. So the MRIs are a little bit less useful. They're neater to look at, I guess. But the CT scans are more to what we go toward to look at those integrities of the bone. A lot of times the talus for rear foot Charcot or ankle Charcot, a lot of times the talus is involved and is extremely cystic and turning into AVN, which obviously can be a major concern if you're trying to do some kind of reconstruction when you're basing all of your stability on a bone that's 60, 70, 80% dead. So this is a chart that you guys can maybe screenshot or something like that. This is a nice little, comparison of osteo versus Charcot. I'm going to give a shout out to my fellow who was on the other line, putting together a lot of this stuff from his residency. But looking at these two charts is really important. A high signal intensity on our MRIs for osteo versus Charcot, which a lot of times has that normal or low uptake on the T1s and T2s. And then the big ones here are circled in red. Marrow edema for osteo tends to affect a single bone versus Charcot, that's multiple bones and multiple joints. And then osteo usually has a higher association with a underlying ulcer with osteo versus no ulcer or no opening in the skin with Charcot. Bone scan, which hopefully everyone's brushed up on their bone scanning for this surprise Charcot lecture, because I'm going to go over a little bit of that today. Bone scans are pretty useful when used the correct way and used on the right patients in correlation with other imaging to diagnose Charcot versus osteo and Charcot and osteo together. Looking at these two, and we'll go into this in a little bit, looking at these two diseases and figuring out which condition they have or if they have a combination of it. So that's the hard part about looking and treating Charcot with a wound, right? So, I have a patient right now that has Charcot, has a wound, but MRI and CTs have ruled out osteo. So it is really important to really combine as many of these imaging modalities that we can in order to properly diagnose these patients. I am not going to go through all this, but this is something my fellow residents and I put together when I was in residency at St. Vincent. And it's a really nice little step-by-step of when you have that red hot swollen foot and if you have a wound versus no wound, and then what kind of leads you down the path of Charcot, osteo combination, or just straight AVN or avascular necrosis of the bones. So, this is constantly changing and constantly updating with new modalities in your back pocket. So, although that chart seems to be extremely like this guy from Always Sunny, it kind of is like a nice little cheat sheet of which imaging to get in which patients. So our classifications, I'm not sure how far everyone is in the learning about Charcot and their education, but this is just for edification purposes. The Eichenholtz is one of the bigger ones that is talked about. There's multiple different classifications, but looking at whether or not they're in the inflammatory, coalescent, or the consolidation phase of these patients. And these numbers that are written in this chart is not a steadfast and true, especially in stage 2. That stage 2 can last for a long time, especially if the patient is not taken off their foot.
Dr. Clougherty, I'm going to go back here for a second. Can you have somebody evaluate that x-ray, please?
Sure, I would love to do that. Who wants to look at this x-ray? Shout out to our 4 externs that are with us. So one of you can go ahead and take this one.
I can give it a go.
Perfect.
Can you hear me?
Yep.
Awesome. Okay. So I see a AP view of the left foot. What's most striking is there's a lateral angular deviation of the foot at the tarsal metatarsal joint and more distal to that, as well as debris and destruction of the navicular And the,
That dislocation, that lateral
oh,
dislocation,
sorry, that medial cuneiform.
that's the medial cuneiform.
Yeah, sorry.
Lateral dislocation. So is that a homolateral, ipsilateral, divergent? How would you describe the? Because if this is essentially a Liz Frank injury in the form of Charcot, so what kind of description do you give that?
I would say homolateral. I think, is it B1 or sorry, A1?
Yeah, if this was if trauma related, yeah. So this is this would just in your read just describing it as homolateral because everything's moving as one unit and not divergent.
So homolateral, lateral deviation, and then kind of tough, but I would just say the tarsal bones show a lot of destruction, debris, and it's pretty disorganized. Significant deformity of the tarsal bones.
Good. So what would you stage this as?
For Eichenholtz, I would say, I don't see, maybe there is a lot of sclerosis, but I would say more the first stage, which is deconstruction. Is it deconstruction?
What stage is it?
Stage one. Stage one? Oh, sorry, development.
Okay, so it probably is, obviously we don't have a clinical picture. So it's probably in the inflammatory or coalescing stage. It doesn't look like there's much fusion going on. Everything's still broken apart. A lot of times it almost looks like a blurred, like someone took their finger and smudged the bones together. That's usually where we look at the bony consolidation portion, which is that stage 3. So this is kind of, new bone production within the midfoot.
Can I ask a question? Would you see this much soft tissue edema in coalescence? Well, I guess you do because it is coalescence, but I would think it would have gone more down at that stage.
Where do you think there's edema?
On the medial aspect of the foot.
Okay, yeah, so that's either, I would guess that's either the bowing of the skin because of the medial cuneiform being shoved to the side, or it could be edema. I'm not sure, but
okay,
it's a
thank you.
good point.
Thank you.
All right, so someone's going to take this one while I talk about this stage 0. So Gerard, you talked about this stage 0, which is essentially just the beginnings of a patient who may develop Charcot in the near future. So a patient who has an acute sprain, acute fracture, uncontrolled diabetes, possibly a history of Charcot in the past, and treating these quote unquote stage 0 Charcots is a highly recommended, especially for patients that have a history of Charcot. It's almost like you already saw this movie already, might as well prophylactically treat them. So who wants to read this ankle film? And this is not Charcot yet, so this is just, it's a normal trauma. Somebody.
I can go for it.
Good.
And so I have a medial oblique view, it looks like, of the ankle. And most notably, I see a fracture of the fibula of the lateral malleolus around the Weber B level.
Okay.
And also possible chip fracture of the medial mal proximal to the distal aspect of the medial mal, so more at the epiphysis of the tibia.
Okay.
in regards to the fragment on the fibula, it seems to be well aligned, but the proximal aspect of the fibula is now shifted into the lateral gutter of the ankle joint and closing the tib-fib gap, making the clear space more narrow than it should be anatomically.
Okay, good. Oops. So without getting into a lot of boring detail, we have stage 1, that acute stage, stage 2 where it coalesces, some sclerosis and resorption of the debris that occurs in the stage 1. And then the consolidation, putting these patients into a crow boot. Now, obviously the big problem with crows are actually getting a patient to wear this bulky, terrible looking boot around because they're heavy, they're hot, and a lot of times they're very difficult to keep patients in, especially if they have a wound as well. They're a lot less likely to be compliant with it. So non-operative treatment is obviously a option. We can gold standard here being offloading and protecting total contact casts between 8 and 12 weeks, non-weight bearing, sometimes longer. Some physicians allow for weight bearing. Some physicians do not allow for any weight bearing. So it's very physician dependent. Obviously, the best treatment is to completely get the patient off of their foot, but we can't always do that, or can't always get the patients to do that for 3 months, 4 months sometimes. That's just a picture of that lovely crow that patients are given. They're fitted for the patients after the total contact casts are used, and then those patients may benefit from a crow later on. So let's talk about surgical treatment. So patients with diabetic neuropathy have a lot higher rates of complications, a lot higher rates of infections and wound dehiscence and non-unions, but that does not necessarily make that a contraindication for surgery, especially if the patient doesn't want to lose their leg, can't lose their leg, and they do want to go through, you just have to have an honest conversation with them that, this is not going to be an in and out, and then you're all healed. Their rates of complications are a lot higher. I like this since Dr. Rosante likes going over X-rays, so someone's going to read this this X-ray in a second. These radiographic measurements as a predictor for ulcerations in a diabetic Charcot midfoot. So this is a really good study to almost point you in a direction of whether or not the patient is going to get a wound and how you can kind of treat it as such. So that lateral talar first metatarsal angle measured on weight-bearing X-rays, which is really important, making sure they're weight-bearing. And that lateral talar first met angle, or Meary's angle, anything greater than -27 degrees, the patient is likely to develop some kind of ulceration. And then Wukich kind of did a spin-off off of that and also suggested that a cuboid height of less than -5 millimeters also is predictive. So who wants to read this X-ray?
I guess I will.
Oh, go ahead.
Okie dokie.
All right, it looks like it's a lateral view of the right foot, and looks like there's sclerosis and coalescing going on in the midfoot.
Okay.
Possibly some hammer toes.
Sure. What do you see with a calcaneus? So it's a big deforming force in Charcot for calcaneus.
The heel spur. It's very elongated, like in a plantar aspect.
Okay. What about the inclination?
It's decreased.
Significantly, right? It's probably negative if we draw these out.
Yeah.
So Aquinas, Aquinas is a large, big driving force of this midfoot collapse of the Charcot. So whenever you're planning these surgical interventions, or non-surgical interventions, but surgical interventions, you want to make sure you're dealing with that driving force, that Achilles tendon pulling proximally on that calcaneus has to be counteracted somehow. So whether it's a tendo-Achilles lengthening, whether it's a gastroc recession, or if it's severe enough, considering doing a complete Achilles tenotomy, or a rupture of the Achilles, and then doing an ankle fusion on that patient in a good calcaneal positioning. So surgical, excuse me, surgical options. So exostectomies, arthrodesis, and amputations. Those are.
Dr. Coleman, a quick question, please.
Yep.
On the previous slide, is that significant soft tissue swelling and edema, or is that just an obese patient?
That is significant edema, and it's also those ripples are usually because they have some kind of lymphedema or ACE bandages, or those lymphedema. What are those called? Compression stockings or compression wraps. That all that edema and all that fat kind of muffin tops. As soon as that ACE bandage shows skin, that's usually where it kind of bulges out.
Thank you.
Exostectomies are most easy and quick fixes for these patients. There's good literature regarding exostectomy successes, both medially and laterally. The more, the lateral exostectomies, the recurrence is a lot higher, and that breakdown is a lot higher than those exostectomies on the right, on the medial portion of the midfoot. I stole this picture, I think it's pretty funny. The arthrodesis is next. So whenever we're talking about Charcot, it's the more the merrier, the more hardware, the better. These super constructs, which, we're extending beyond the zone of injury, i.e. Those plates and screws, they go both proximally and distally past the area of the Charcot destruction. You want to resect enough bone for the reduction of the deformity. All that, once it's coalesced like that, it's very hard to get the bones back into alignment without, re-breaking. The doctor broke my bones and put it back into normal. So that's exactly what we have to do. It's a lot of carpentry work to even get all the joints back mobile again, to then put them in a good positioning. And then making sure that we're adjuncting as much as we can when necessary. So external fixation is a big go-to for Charcot. And there's a big debate whether or not you do internal fixation, external fixation, or a combination of both. And then everyone has their opinion, and it's usually based upon what worked for them through the years. So I'd like someone to read this X-ray. This is a really good pre-reconstruction X-ray. So if someone wants to take this, just for the post-reduction and post-fusion, it's a very rigid construct. There's plates and screws and bolts. Midfoot patterns, usually there's a lot of hardware that has to go through the midfoot because that's where that collapse happens. And then using external fixation to stage it, or if there is a wound, or if there isn't a wound, using external fixation. So who wants to take this X-ray on the left-hand side?
I can take a whack at it.
Okay.
Okay, so you're looking at AP view of the left foot. I see midfoot collapse. I see divergence at the Lisfranc joint. The medial cuneiform and the other cuneiform joints looks like it's dissolving, and it just looks like the foot's widening. I don't see any edema or signs of gas or infection.
So if you said dissolving, what's a better term for that for radiographic? That's an R.
Starts with an R. Resorption.
Yeah, exactly. So
Bone
there's
resorption.
resorption of bone and then building back up a bone. So you can kind of see here that there's some kind of pseudo fusions that are occurring, right? So like, can you see my mouse move?
Yes.
All right, so see right here, you have some callus formation and some bony product that's being laid down to try to stabilize that unstable joint. You had a good, so you have a divergent Lisfranc here, but we also across the talonavicular and the CC, the calcaneocuboid joint, you can kind of see here, instead of a flat foot where the talus is medial, swings out medially, this whole navicular is swinging out medially. So this whole midfoot here, it almost looks like the fifth ray and lateral calcaneus, and the first ray and talus are in pretty decent alignment, but this whole midfoot here is shifting almost completely medially. Good on the read. So, and then ankle reconstruction. So, you know, a lot of times you have to look at where the driving force is for these Charcot and address it as such. So, you know, if you have a Lisfranc, let's say, Charcot that's going on, is it the Lisfranc joint that, you know, if you just put some plates and screws on there, will that come back, or is that stable enough? Because what's really the driving force? Is it truly just in the midfoot, or is there some ligamentous laxity in the rear foot that needs addressed? That's why I'd say probably 99% of my midfoot fusions for Charcot also get at least a subtalar joint fusion, if not subtalar joint and ankle joint. That subtalar joint collapsing in the pronation portion puts so much stress on that hardware after you do a midfoot fusion, that kind of creating this stable tripod of a foot is extremely important. All right, so I have a really kind of decent case. It'll take us a little bit to go through. So if someone wants to volunteer for this, spoiler alert, it's Charcot. But I want someone to kind of go through this case, and then some X-ray and CT scan reads as we go through. You don't have to do the whole thing, but at least get us started.
I can start it for you.
Awesome. So I'll give you a little background of this patient. He's a 73-year-old Caucasian male. He came to the wound care center after being treated at St. Elsewhere for a little over a year. He had bilateral wounds, but this wound is the main one now on the right-hand side. A significant past medical history. Obviously, he's not a pinnacle of health, very unhealthy individual. Good news, I guess the only good news is denies any tobacco use. And he recently had a large weight loss over the past 6 months. Vascular was intact. He had some edema and erythema, loss of all the protective sensation up, up to mostly the ankle, and then kind of diminished proximal to that, and then a full thickness wound. And then there's our kind of a classic rocker bottom foot that you can see here. And then here's just a couple pictures of the lateral portion, the medial portion, and then the erythema around there. All right, so 73-year-old male. Give me your read on these 3 exercises.
Okay. I see an AP view, a medial oblique, and a lateral view of the right foot. On AP, attention can be drawn to what looks like lateral deviation of the metatarsals at the tarsal-metatarsal joint, with some resorption of the midfoot bones there, the navicular, cuneiforms, and the cuboid. Let's see here. Talus looks fine. I don't see too much soft tissue swelling or anything of that nature. I do see on the lateral view, looks like a break, should I say, at the base of the first metatarsal. So would you call that a fracture at that point, or would, yeah, okay. So fracture at the base of the first metatarsal. Don't see too much else. I don't see anything on the medial oblique. So I don't think any of the bases of the lesser metatarsals are fractured, but it does look like the cuneiforms are pretty much gone. Can't really differentiate between any of them.
So if you remember the clinical picture, there's something that was a good Charcot read, but there's a clinical portion that you need to address whether or not it's positive, negative, questionable, etc. So what portion of the clinical photo are we worried about?
Can I see that photo again?
Of course.
You're worried about both looks like the plantar aspect at the heel there, and then the plantar medial aspect at the navicular.
Right, so we have a wound, so our x-ray read, because you know the clinical portion of it, it does need to address whether or not there is questionable, what?
Infection.
Exactly, so whether or not there's osteo or not. And then,
there could very well be osteo.
Okay, and why do you say that?
Just due to the destruction of the midfoot bones there, they look very fuzzy, which can be typical of osteomyelitis destruction.
Good. So our initial wound cultures showed our typical Pseudomonas. I don't think I've ever seen a diabetic wound that doesn't have Pseudomonas in it. And then a staph. So patient kind of disappeared, wanted to get his life in order, and I won't make you reread this, but essentially you can kind of tell there's a lot more destruction that has happened over a 2-month period. So we have looks like the cuboid that's fractured planarly. That medial column is now, that Meary's angle, if you look back, it wasn't too bad. I mean, it was off, but it wasn't too bad. And now looking at this, I mean, that first metatarsal is a full metatarsal length above where it was before. So obviously we have a pretty good Charcot. So patient's labs were a little bit off. He had a elevated SED rate and a CRP. So what does that kind of indicate whenever we have a high SED rate and CRP?
Infection.
Good. So what kind of ancillary studies would you want to get?
CBC.
Okay, what else? Not labs.
Okay.
Like imaging.
Oh, okay. Imaging. MRI would probably be best at this point, just so we could differentiate between any areas where it was just Charcot or just infection, or what was going on exactly.
And then what other options would you want to?
You could also get a CT if you just wanted to see about the bones. Then you could do a bone scan as well.
Good. That's good. So how about we have somebody go through the CT scan that we got for this patient. Who wants it?
I could continue if you'd like.
Okay, go ahead.
Although I've got to be honest, I don't know quite what I'm seeing here.
Okay.
It looks
So go ahead, give it a shot though. What are we looking at?
see tibia with talus a bit. It's really all I can make out. So it's probably a coronal CT.
And then how about here? What do you see? What do you see here?
It's calcaneus and submeta. So it's an axial.
Okay. A lot of fragmentation.
Yeah.
Right. So, and the integrity of a lot of the bone is not there. So the next imaging here, which I'm not expecting you or anyone else to really know, is this bone scan. So there's a couple different bone scans that can be done, and then you're looking for an increased uptake in the images and in certain locations, right? So it's kind of looks like a TV from the 1960s, 70s, but that fuzzy and bright uptake on the right foot, and kind of allows you to see whether or not there's uptake in the distal foot, in the proximal ankle, and then everywhere in between. And then here's our delayed scan, our triphasic scan, showing the immediate, the stage 2 and 3, and then the delayed, so the 4-hour delayed. So that allows us to see how much involvement is soft tissue versus a bone infection, which obviously would keep that uptake in the longer periods, versus Charcot, which does not keep that uptake. So this is a example of this patient's serotech scan, the white blood cell labeled serotech scan, or an indium scan, also known as. So just to show you the phases of that serotech scan. And then the MDP scan, which is also utilized to overlay the two and look at the 24-hour delayed bone scan. So this shows that because there's still uptake after 24 hours, this indicates, or this scan indicates, whether or not there's infection in the bone, or there was just a Charcot, or there is a Charcot process that's going on. And
so if there is uptake at the 24-hour point, then it's infection, or is it Charcot?
Yep. So you have this indicates that there is a Charcot process, that yes, there is a Charcot that's going on, but because there is still uptake after 24 hours, there's also an underlying bone infection or osteomyelitis. And I had no idea how to pronounce it, so I just wrote it. Okay, so here's our scans. We had increased uptake in the Tech99 scan, the serotech scan, and the MDP. So we have Charcot and osteo combo. So for time purposes, I'll just kind of go through the what we did for this. So this is a great example of a staged procedure that needs to be done. Can't be putting, so if you're going to do a reconstruction, the last thing you want to do is put hardware into infected bone for obvious reasons. So stage 1 included a bone biopsy and static external fixation, PMMA beads and a block with vancomycin added. For this patient, we use bisphosphonates, which is in the literature used for Charcot patients. A PICC line with IV antibiotics for 6 weeks, and then sent to a facility with weekly wound care. So here's just an example of the PMMA spacer block on the left-hand side, and then the beads on the string on the right top. External fixator utilized in lieu of internal hardware, especially when you take out so much bone. You don't want this floppy foot just kind of hanging out in the breeze. So you can appreciate right here, that circle that I'm circling right there is the block, which is where the bone was taken out, the navicular was taken out because of the infection. And then right across the midfoot here, there's those string of pearls or those beads placed right across. Bone was infected from the midfoot. External fixator utilized for a while just to kind of keep everything stabilized. After 4 weeks and then 6 weeks, decided to adjust the frame. Started getting what we like to call cage rage, which is exactly what it sounds like. These patients feel like they're in jail or under quarantine. And a lot of times you can't keep them in there because they go into a lot of almost like a depressive state. So external fixator the second time around was not an option for this patient. Could tell that he wasn't able to handle that. So about 10 weeks after the initial excision, utilization of a fresh frozen femoral head, some bone substitutes and cancellous chips, and then we kind of used a bunch of hardware in there. So not necessarily a super construct, but a pretty strong construct for this Charcot patient. The beads and the block are taken out, they're recultured, make sure there's no residual infection with a stat gram stain that we can do in the operating room. And then after that comes back negative, we can put the hardware in. Here, it's a nice little recreation of subtalar joint fusion, a midfoot fusion, lateral and medial column beaming with these headless screws, and then plates on the medial portion for some extra construct. Kind of skipping through here, patient went through multiple cast changes and all that stuff, placed into a AFO brace, and then around 12 weeks post-op, finally got him to start walking again. Ironically, this patient, sorry, I'm kind of flipping through, but ironically, this patient was getting back surgery about 16 months later, and we ran into him in the preoperative area. We were doing surgery on somebody else in the same day, and asked him if it was okay if we got some post-op x-rays after his spinal fusion. We ordered one ankle films. He was okay with that. So about 16 months post-operatively, still has a great plantar grade foot for ambulation. And then these are his x-rays. Everything looks pretty solid still. He's obviously walking full weight bearing in that. It's not pretty looking, but it serves its purpose for this patient. He got a good fusion out of it. So that just shows what it looked like in the beginning, and then what it looked like 16 months after his final procedure. All right, I think that's it. Yep. So are there any, Dr. Rosante, are there any questions I need to address from the chat room? I didn't have it open. It was
no, I was taking care of the chat room today.
Oh, thank you.
I have one question.
Yeah.
So you brought up your superconstruct article by Samarco. What's the fifth principle? Your walking beaming?
Say that one more time, I'm sorry.
You brought up a fifth principle, which I'd never heard of in the slide.
I'll go back to it. Yeah, utilizing locking.
Yeah.
Yeah. I can try to find that article and send it to the group that gets these if you'd like.
When you're done with this, we have one more question from the chat room too.
All right, fire away.
Hey, Dr. Clougherty. I have a question about Cora in terms of like fixation with Charcot. Is there any way you could kind of talk about that a little bit?
Sure. So core is the center, essentially where the major, hold on, let me finish that first one. These locking the beams. So I think that's a newer article. I'll have my fellow grab that article for you guys, and we'll send that out. But pardon me, that that locking the beam, so utilizing some kind of locking technology in combination with the beams. So core is really interesting whenever you're talking about deformities. It's the center of the deformity and where most of the deformity is. So everything that you have to correct centers around that cora. So what you do is usually the core is where the osteotomy is performed. Usually that's where the wedge is taken out of, whatever correction you're trying to get. If you're taking out a 3D wedge to address a sublux joint or a mal-aligned joint, core is used a lot in long bones. That's usually where most of the literature is about it, and that usually has to do with femoral or tibial deformities in the lower extremity or in the extremities, and that cora is where you're going to get all the correction or most of the correction by doing all of your work starting in that location, and then kind of supporting everything around and around that major deforming force.
Thank you.
Anything else? Dr. Rosante, anything else from you?
No, thank you very much. If you can get me a PDF of the PowerPoint or a PDF of your presentation, I'll put it in the link to the YouTube video page so everyone can download it from Google Drive.
I can do that right now.
And that's it. So we will get an email out soon about Friday. We're going to have some power and do some procedures. So since we have power, we may limit or not do any cases beforehand so we can do more procedures. But we're trying to decide that within the next day or so. And then next Monday, I will do radiographic angles of the foot. And then hopefully after that, we can get Dan's second half of open fractures done the following week. Or we may have him just do it beforehand, our presentation this week. So we'll figure out some details and get emails out there. Thank you all for paying attention.